just see their round foreign body. And the thing that we most pay most attention to these days is the butt and battery ingestion, mainly because they're an absolute disaster in the esophagus. They're not so bad if they get down into the stomach, and they're not such a big deal if they get beyond the stomach. But butt and batteries erode the esophagus incredibly quickly. There's been children die, there's been cervical osteomyelitis. It doesn't take long. So these days, if we have a standard order for question mark, butt and battery, and we'll pretty much do sort of neck, chest, and abdomen to look for the battery. It's useful. The main thing in the abdomen with the foreign bodies is they just want to know if it's in the stomach or not. And so there's some form of metallic foreign body here. Looks like it's in the stomach. They usually don't go and fish them out unless they stay in the stomach. And certainly once they're beyond the stomach, there's not much they can do. So foreign body in the abdomen, is it in the stomach? It's pretty much all I want to know. Pyloric stenosis, hypertrophic pyloric stenosis, generally referred to as pyloric stenosis. So idiopathic seems common. So it's listed at 2.5 to 3 per 1,000 births, but these days I'm sure there's far more ultrasounds done for pyloric stenosis than that. Classically, progressive vomiting leading to failure to gain weight and then eventually weight loss. So in the old days, babies used to present losing weight, thin, this sort of old man faces, hypochloremic alkalosis. I think that's pretty rare these days, and I think you're far more likely to encounter a baby that's just spitting up a bit of milk for rule out pyloric stenosis, and in some respects that makes life a little bit more difficult. I think everyone's familiar with the general principle of thickening of the pyloric canal. Doesn't start out abnormal, progresses over time. I just put for interest there the flow chart from the Children's Hospital in Victoria, and imaging just rates are mentioned. So the old days, I don't know if the old days of palpating the abnormality are still around, but we certainly get asked to do a lot of these. Diagnostic criteria. Now, there's a lot of them around. I don't know that everyone agrees on what the diagnostic criteria are, but generally speaking, it's a single wall thickness greater than 3 millimetres, pyloric channel greater than 16 millimetres, pyloric diameter in total greater than 15, and mucosa tends to hypertrophy, become redundant. I think you can see there, we look at it with linear probe. General rule is you find the gallbladder, and in that region you should be able to find the pylorus. Picture on your top right is the sort of picture that we like to see. You can see in longitudinal there the pylorus. It's measured, but you can see the stomach muscle just on extending to the right of the screen. So you can see the difference there in the thickness of the stomach muscle or stomach wall muscle versus the pylorus. When it comes to the criteria, what I tend to use is I would say that if it's less than 14 millimetres, you can't make the diagnosis. Now it can be early, but I wouldn't make a diagnosis less than 14. Greater than 16, you're pretty much dealing with pyloric stenosis. The other things that you have to put in the criteria are that you have to have a full stomach, and one of my rules is that I've never seen one that hasn't presented with a full stomach. I think if the stomach's empty, the baby's got a lot of work to do to convince me that it's pyloric stenosis, because I've never seen one that's empty at the time when the baby comes down. So we like to see full stomach, whether it's at the time, presentation, or with a test feed. We like to sit there and watch the peristalsis of the stomach. So you see the gastric peristalsis, and despite gastric peristalsis, despite a full stomach, the pylorus doesn't open, then you can be pretty confident. So certainly if you've got more than 16 millimetres, full stomach, good peristalsis, a reasonable period of observation and the pylorus not opening, you can just say this is pyloric stenosis. Less than 14 millimetres, well, sometimes it can be hard, and this is probably the situation you're in more commonly these days. And so it's the equivocal pyloric stenosis, the early one, and this is where pyloric canal is a little bit abnormal. It's 14 to 16, and in my experience, most of the time they end up being pyloric stenosis. As I said, the baby turns up with an empty stomach, or the pyloric muscle seems thickened. I think in this case it was 2.5 or so. Pyloric canal was about 16 millimetres, but during observation, the pyloric canal opened. So really in this sort of situation, it's equivocal, it's opening. You can't call it pyloric stenosis, but it's probably early pyloric stenosis. So there's many of these. This is more likely what you're going to get into. You're either going to get a canal that's elongated, the stomach's a bit full, you don't see it open, or alternatively it's a little bit elongated, but you seem to see a bit of milk or water going through. So most of these will go on to be pyloric stenosis. When it comes to the test feed for these, I don't know if I mentioned that on the next slide. So if the baby comes down or comes to us with an empty stomach or a stomach that isn't particularly full, we will take the measurements, and you'll often get a measurement of the pylorus that seems elongated when the stomach's empty. So then we go on to give them a test feed. Sometimes we ask, a lot of times we don't ask. I don't think seriously that babies should ever come fasted for pyloric stenosis, and chances of getting an operation inside the fasting time are pretty much zero anyway. Fasting time for a breastfeed baby is about 2 hours, so they're not going to get an emergency theatre in 2 hours. We start with water with a test feed, mainly because milk is a little bit echogenic and can make it a little bit harder to see. So we like to fill the stomach up. We generally start with water. Generally the baby figures out that that's not what they're after, and then you have to give them some milk. So you get a little bit of particulate, a little bit of echogenic material in the stomach. But nonetheless, once the stomach's full, you can see peristalsis. If it's equivocal after a test feed, it's probably better to report it as equivocal. Obviously, if with a test feed the canal shortens and opens wide and milk just surges through, you can report it as normal or certainly not current pyloric stenosis. A lot of times you end up doing another ultrasound in a few days' time. Most of the equivocal ones go on to being diagnostic. We see this quite often. The scans coming in where there's a 20 millimetre canal with 5 millimetres of wall thickening reported as equivocal. It seems to be lack of confidence in diagnosis despite unequivocally positive scan. Elongated canal with empty stomach, I've already talked about that. I've seen this happen. This has happened to me twice, and just keep this in mind that this can happen, is that you get images of, oh, I saw the gastroesophageal junction open, when in fact what they've taken photos of is the gastroesophageal junction. So if the heart's in the picture, it's not right. Okay, next condition. I know most people won't encounter this, so I'll try and be relatively quick on this, and this is malrotation of midgut volvulus. Most people won't encounter it because it's a condition that occurs by far the most frequently in young babies and is diagnosed in the first month of life. For those that aren't familiar, malrotation simply refers to abnormality of the normal rotation and normal arrangement of the small bowel mesentery. So on the bottom right is normal, with the straight line representing the normal attachment of the small bowel mesentery from the DJ flexure down to the cecum. So that's a long attachment of small bowel mesentery and not prone to twist. With malrotation, the picture in the centre, or the diagram in the centre, the bowel hasn't rotated normally, the mesenteric attachment is very short and prone to twist on itself. As I said, most of the time this condition presents in the neonate, but sometimes comes along a little bit later in life. Now, the diagnostic test for this is the contrast, upper GI contrast there, and what we expect to see, or what the textbook tells us we're always going to see, is full and dilated first part of duodenum, first and second part of duodenum, as you can see in that picture, with then a corkscrew appearance of the small bowel descending directly inferiorly or inferiorly and to the right without ever crossing to the left when there's volvulus. When there's not volvulus, simply abnormal position of the DJ flexure with more of the bowel on the right than the left. So most often babies will be sent with bilious vomiting, which is often more of a rumour than a reality. The baby comes in, the vomitus or the nasogastric aspirates are either clear or yellow, and we just have to demonstrate that its DJ flexure is in normal position. And the normal flexure of the normal position of the DJ, all we really need is 2 X-rays. A lateral showing the first part of the duodenum to go posteriorly, the second part of the duodenum to run parallel to the spine, and that's the image on the top right. Then we flip the baby onto their back and we expect to see the third part of duodenum ascend and the DJ flexure to lie to the left of the vertebral body pedicles and at about the level of the pylorus. Now the difficulties can be that, well, there's a few difficulties, but one of them is that in the neonate, DJ flexure is a little bit more mobile. So particularly if the stomach's full, it can look a little bit pushed down. There are some other difficulties, but I'll just show some of the examples of what it's supposed to look like. And so on your left, malrotation, but no volvulus. Normal stomach, no dilatation of duodenum. Second, third part of duodenum just seems to go from the midline directly inferiorly, and then most of the bowel lying on the right. That's the sort of picture you might see with children who present a little bit later in life. So we sometimes see this with kids that are a bit later, have some vague history of vomiting repeatedly, maybe bilious. They sometimes have an ultrasound that may show abnormal orientation of SMA and SMV, with the SMA lying to the right rather than left, and have the diagnosis of malrotation on a contrast study. The other picture there, lower on the right, is what it's supposed to look like with volvulus, which is a corkscrew type of appearance, although that's what they tell us. Only difficulties you have with this diagnosis are that the normal anatomy can be quite difficult to capture. If the baby's normal, it passes rapidly through the duodenum. If you don't get it the first time, there's a lot of overlap of contrast, and it can be quite hard to get it if you don't capture it the first time around. The other difficulty is that when the babies actually have malrotation volvulus, they're often quite ill, and there is can be quite a delay in gastric emptying. Technique, we always use dilute omnipaque these days since Polybar went out of production, but dilute IV contrast is what we use. It's really quite helpful to just, particularly if you've got staff who aren't familiar with the procedure, just to tell them what you're about to do, and that is turn the baby left, right, and try and stop the baby moving too much inside the field of view so that you capture the first pass. Comb the images as usual with screening and watch the screening time. Now, as I've said, when it comes to the babies that actually have green aspirates, they're ill, and often it's some delay in gastric emptying, or if you miss it, it can be hard to show the normal position of the duodenum. I don't hesitate these days just to put in a transpyloric tube. In fact, the older I get, the quicker I am just to put a tube straight into the duodenum, inject contrast straight into the duodenum, you get your answers straight away. Saves a lot of mucking around if it's difficult. So consider that if you have a TPT to hand. And this is an example. This is a baby who had green aspirates, and we put the contrast in, just didn't go anywhere, just didn't go past second part of duodenum. Put a transpyloric tube in, just into the second part of duodenum down there in the bottom left, injected straight into duodenum, still wouldn't go anywhere. Bit of dilated duodenum, went backwards, not forward. So seemed like there was an obstruction, but we just couldn't show that classic corkscrew appearance, and that's sort of sometimes where you're at. Occasionally, if you do that, hopefully this plays, we finally convinced the surgeons that it was malrotation volvulus with the ultrasound, and I think, hopefully, if we can see on that clip that you see that, oh, no, sorry, whirlpool appearance of, I don't know if that'll play again. Just that whirlpool appearance of the SMA and SMV as you come down the abdomen, convincing them that this was a volvulus. Okay, next condition, intussusception. Condition we get asked to rule out far more often than we find. I don't know how often we find intussusception. It must be less than 5% of the ultrasounds we do for intussusception. So the important thing to know what to do with intussusception is how to rule it out. Ileocecal versus small bowel. What we're looking for is ileocecal. That's the one that causes problems. That's the one that we have to treat. Small bowel is pretty common. In fact, it's probably the commonest referral to us from the surgeons is for intussusception diagnosed that actually is small bowel rather than ileocecal. So important to know what they look like. I know that in the old days there were these descriptions of pseudo-kidney and target and so on, but that's what they look like. That's what they always look like. You can see rounded mass. There's a little bit of echogenic fat from the mesentery trapped in the intussusception, and there's usually a couple of ovoid hypoechoic lymph nodes in the centre of it. So ileocecal intussusception. Most of the time you'll find it on the right side, but it's quite important to recognise that it can be anywhere in the bowel, including all the way around. And even prolapsing out. So just because you don't find one in the right iliac fossa or just under the liver doesn't mean there isn't going to be one there. So should expect to see the intussusception in the general course of the large bowel. The ones that we get referred in that are small bowel intussusceptions, they're usually more central, not in a position you expect to see a ileocecal. They don't look like that. They don't have the mesenteric fat. They don't have the lymph nodes trapped in them. They're smaller, and often they're mobile. If you sit and watch them, they'll sort of accordion in and out, and you don't really see that with ileocecal intussusception. So I don't know how often anyone here has seen incidental small bowel intussusception, but I think they're actually quite common. If you want to see one on a plain X-ray, that's what it looks like. It's normally supine X-ray. You expect to see a continuous column of gas in transverse colon. You have a soft tissue mass sitting under the liver, interrupting that gas column. That's what it's. When it's on a plain X-ray, that's what it looks like. Some of the things that we look for, we try and add a bit of value here when we do this, is we do look for a lead point. We almost never find one. If you find a lead point, it's going to be something like a duplication cyst that occur around the ileum. So we look for one, virtually never find one. Look for free fluid and obviously any other collections. Now, when it comes to ruling them out, if you can show a normal ileocecal valve, so if you can't find an intussusception, next thing we would do would be try and show a photo of a normal ileocecal valve. If you can show that, there is no current intussusception. So try, if you can, that's good. If you can't, it's useful to show, I always like to have a photograph of gas in all four quadrants, just to show that you've looked around the whole colon. You can show there's gas at the flexures, gas down in the sigmoid colon, and you've looked at the whole colon, there isn't one that you can show, because it's just nice to document. Document absence of something is hard to do. When it's positive, as I said, fluid, lead point, and colour in the intussusception. Colour on the Doppler is just useful if you're going to do the reduction. Obviously, current thinking is that if there is a perforation when you're reducing these, that there's probably a pre-existing perforation and all you're doing is really opening it up. So the ones that you're at risk, that we're at risk of perforating, are the ones that are really sick to start with, and the indicator, or one of the indicators of that, is poor colour flow in the intussusceptum or intussuscipiens. Free fluid in the abdomen is pretty common. Don't pay too much attention to that. Lead point, well, very uncommon. We tend to show it, I didn't mention, we tend to show it in long and transverse for what that's worth, just to give an indication of the length of the intussusception. Okay, appendicitis. Spend half our life looking for appendicitis, and whole range of abnormalities that we might see on imaging for appendicitis. School-aged child with bowel obstruction, it's obviously the first thing you think about. If all you have is a plain film, bowel obstruction, vague increased density in the right iliac fossa, it's probably appendicitis. If you see an appendicolith, almost certainly appendicitis. Not that there's one there, but if you see that, so it's worth having a little search for an appendicolith in that setting. But nonetheless, bowel obstruction, vague density, right iliac fossa, probably appendicitis. But these days, ultrasound is what we're asked to do. And again, we find ourselves ruling them out far more often than actually finding an appendix. Even in people who do it all the time, it's not always demonstrable. But I think we can add a little bit of more value than that. So when we see an appendix, there's variable guides that you can use to whether it's normal or abnormal, but data says if it's less than 6 millimetres, it's pretty unlikely to be acute appendicitis. So less than 6 millimetres, pretty good at ruling out acute appendicitis. Absence of free fluid. So if you can't see the appendix, you can at least look for free fluid in the right iliac fossa. So combination of not seeing an appendix plus no free fluid in right iliac fossa and no free fluid in the pelvis and no inflammatory change in the right iliac fossa, probably not appendicitis. So there's some useful secondary signs to look for. Other things that we routinely comment on, whether it's compressible or not when we can find it, and whether there's tenderness to ultrasound probe pressure. I don't know how useful people regard that, but we always comment on that. In terms of technique, everyone's probably familiar with that. We generally start with a curved probe but then go on to use a linear probe. Just gradual pressure in the right iliac fossa, usually find the psoas muscle and the iliac vessels and try and find our way up using some pressure to the ileocecal valve, find the cecum and the ileocecal valve, and then just sort of slide down a little inferiorly, see if we can see the appendix come into view. So some images there of a normal appendix, slender, sitting on top of the psoas muscle there, no surrounding fluid, and the adjacent bowel looks pretty normal. So appendix, I don't know there's that many pitfalls when it comes to the appendix. I guess one is 6 millimetres is a good cut-off for negative. Greater than 6 millimetres isn't so good for positive. Around 60% if it's greater than 6 millimetres, if that's the only finding. If you use a cut-off of 8 millimetres, it's a little bit more sensitive for appendicitis. Secondary features. So this is some of the secondary features. We see an appendix up the top left there, where actually we don't. Not top left, we see bottom left appendix walls a little bit thickened, but top left we see an appendicolith, so that little shadowing curved echogenic structure sitting just underneath that loop of bowel is the appendicolith. So if we In addition to that, measured down the bottom right is a little bit of periappendiceal fluid and probably a little bit of increased vascularity and a little bit of increased echogenicity in the surrounding fat. So the combination of appendix looks a little bit plump, pendicolith, a little bit of periappendiceal fluid, probably going to report something like that out as compatible with acute appendicitis. Absence of the secondary features and a 7 or 8 millimetre appendix in the appropriate clinical setting would be supportive of appendicitis. Sometimes it's perforated. In fact, not infrequently the appendix is perforated, and there's a huge variation in what we'll find on the ultrasound when the appendix is perforated. A lot of times you won't see the appendix, or you'll see what looks like a pretty normal appendix or a pretty normal calibre appendix. You just can't see the tip. And so if you're seeing a lot of periappendiceal or pericecal fluid, particularly if you see echogenic fluid and you see the appendix but you can't see the tip, you probably have a perforated appendicitis, and usually they're quite tender in the radial fossa. So I think the periappendiceal collections and the pelvic collections are very useful things to look for. Positive findings, and then even if you see appendix not thickened, it's probably appendicitis but perforated. Just an example of radial fossa and pelvic collection. Bowel obstruction, vague density on the right, perforated appendicitis. You can report it in many ways, depending on how helpful you wish to be. So sometimes people say appendicitis not identified, therefore not excluded. It's nice to go a little bit further than that sometimes, as I've alluded to. No secondary signs, I think is useful information. Equivocal ones, well, it depends on the clinical setting. And then through to findings of acute appendicitis and appendicitis with probable or obvious rupture. Differential diagnosis. Sometimes, particularly in the perforated ones, the bowel looks a bit thickened, but if you can see a normal appendix where you can't see the appendix, but you just see distal ileal, terminal ileal thickening, it's worth mentioning. Differential for terminal ileal thickening, well, sometimes, or a lot of times, it'll go on to be Crohn's disease. So it'll be the first presentation of Crohn's disease. Looks a bit like appendicitis, but all you see is terminal ileal thickening, with or without free fluid. Other causes in children, small bowel thickening, well, enteritis, not that common unless child happens to be neutropenic. Henoch-Schonlein purpura is one that is pretty uncommon to turn up just with abdominal pain, but sometimes it does. That top right's an example of presentation of abdominal pain, terminal ileal thickening with Henoch-Schonlein purpura. Not very common, these sort of what you think of more as adult conditions of epiploic appendicitis and a mental infarction, but just occasionally it does turn up in children. And so bottom left, I think was epiploic the bottom left two images, epiploic appendicitis, young person, I think about 9 years of age, just some echogenic fat down in the radial fossa, avascular echogenic fat. Bottom right-hand side looks very similar. You can't really tell the two apart. That was no mental infarction. Similar position, similar appearance with echogenic fat. So there is a differential. Just to mention it because it's such a classic and typical appearance, if you happen to see this sort of thing with pretty striking bowel wall thickening and ascites, Burkitt lymphoma tends to occur around the ileocecal valve in children. It's usually not that subtle, as you can see, with all that ascites, dramatic bowel wall thickening and mesenteric thickening, and pretty extensive abnormality on the CT scan, but if you're unlucky, you'll see that from time to time. I'm going to mention ovarian torsion, only because it's sort of a way for us, or ED more, to get an ultrasound for appendix when a patient happens to be female. Ovarian torsion we get asked to look for all the time, and I think we might see one a year. one or two maybe a year. That's very or quite uncommon. However, it does occur. It does occur in all age groups. It's worth noting that the adnexa in children is a bit more mobile than in the adult. Now, we have the difficulty in children of only being able to use a transabdominal approach, and so blood flow detectable in about 80% of, or said to be 80% of normal prepubertal ovaries. That obviously is dependent on a full bladder, and that is the difficulty. What will you find? You may or may not find a mass. There's not always a mass, cyst or anything else in the ovary. The finding is usually unilateral ovarian enlargement, and I know that, or I think that in adults there's a guide of ovaries usually more than 20 cc's. That's certainly not a fixed rule. I think that really what you're looking for is asymmetry in the ovarian size. If the ovary, if one ovary is more than 5 times the size of the other, you certainly have to think about it. The torted ovary often lies in the midline rather than in its normal lateral position. So colour Doppler, well, colour Doppler, don't rely on it. You don't always see it in prepubertal ovaries. Just an example of a torted ovary here, and this was a little bit bigger. It was more than double the size of the other side, but it certainly wasn't dramatically enlarged. I think the ovarian volume in the involved side was about 8 cc's, and in the uninvolved was about 2. So marked, so in the appropriate clinical setting, marked asymmetry of ovarian size with or without abnormalities of colour flow, certainly worth mentioning. I just want to mention testicular torsion. Not even sure it's in the abdomen, but just because I mentioned ovarian torsion and we get asked to look for it all the time. All I want to say about that is if you ask Google, it will tell you that testicular torsion in children presents with obvious findings on ultrasound. One lights up like Disneyland and the other there's no colour. Well, it's actually very hard to find colour flow in a normal prepubertal testis. So the colour flow, don't rely on it. In fact, we don't like doing it in prepubertal testes for that reason. I'm sure you're all aware that between the age of about 3 months and in boys 11 and a half years, the testis there's no LH, there's no FSH, it's not stimulatable, it's not functioning, it has no reason to have a high blood flow. So when we find colour flow in the centre of a testis in a boy, it's usually 3-4 centimetres per second. It's quite difficult. There's not really much blood flow there. Even on an image like that, which is said to be obvious torsion, and yes, it's obviously asymmetrical, but the peripheral or the peripheral flow in the testis is not what we should be looking for. The capsular arteries aren't what we're worried about. We're worried about the arteries into the centre of the testis. So I guess if you can show that the flow in the testis and the grey scale in the centre of the testis is perfectly symmetrical, well, it's probably not currently torted. If the apparently involved testis has more blood flow than the contralateral or uninvolved side, well, it's probably not torted. If there's grayscale abnormalities, like there probably is on this, where there's some heterogeneity of echotexture, some hypoechoic regions, and probably some slight enlargement of the testis, then it's quite possibly torted and quite possibly long-standing, or at least beyond the 6 hours. So anyway, that's just the thing. Testicular torsion, don't rely on ruling it out. We don't see the blood flow in the centre of a prepubertal testis particularly reliably, so just be a bit cautious about the way you approach that. Abdominal masses, there's a lot of them. I don't want to mention them. The abdominal masses generally in children, generally when they present, are really not that subtle. They're usually huge. It may not be possible to say exactly where they arise on an ultrasound, but usually they're detected. The only one I can remember that wasn't detected when it was in fact photographed was a neuroblastoma, where there was a little bit of really isoechoic with liver, or maybe it was slightly hyperechoic material that was lifting the aorta. And so anything in behind the aorta is obviously a little bit suspicious. This is just a large neuroblastoma that's displacing, in fact squashing the kidney. Again, just example, mesoblastic nephroma. Again, the abnormality is usually not that subtle, they're usually pretty large. Okay, the last thing I want to talk about briefly, just because it's so common, is renal pelvis dilatation. And quite these days, very often found in utero, and I'm sure most people here will have had the experience of having to follow this up. And so I just got a few comments to make about it. And first of all, the standard definition. So the way we usually define this is measured at the in the transverse plane. We measure the AP renal pelvis, so where the renal pelvis exits the kidney. General definition in the neonate will be less than 5 millimetres. AP is normal. 5 to 9, 5 to 10 mild, 10 to 15 moderate, and greater than 15 millimetres severe. If there's an extra renal pelvis, we generally measure it and report it as separate, as a extra renal pelvis, but the real measurement that you're worried about is the AP renal pelvis. But when following these up, what everyone's really interested in hearing about are the other findings. And the findings are whether there's calyceal dilatation and whether it involves the major or the minor calyces. And so it's useful to be quite specific about the degree of calyceal involvement. And then in the longer run, the thing that people are interested in hearing about is the cortical thickness, cortical echogenicity, and corticomedullary differentiation. So they're the things to really pay some attention to. There's a fairly wide differential diagnosis for renal pelvis dilatation. Transient or self-resolving, by far the most common. When there's a pathologic diagnosis, PUJ obstruction is the most common, followed by probably reflux. Congenital megaureta. Obviously you see more than just the renal pelvis dilatation, you see ureteric dilatation, and that may be obstructed or unobstructed, refluxing or non-refluxing. Then some other abnormalities, whether you think the kidney is duplex, has a duplex collecting system, worth observing. Uncommon ectopic ureter. Posterior urethral valves has a slightly different presentation. I'll just show some pictures of that later. Other urethral stenoses or anterior urethral valves, pretty uncommon. So when it comes to likelihood of prenatal, postnatal pathology, I think it's quite important to recognise that unless you have severe dilatation as defined by greater than 15 millimetres in the third trimester, most of it's going to resolve. And certainly if it's less than 10 millimetres, chance of finding any pathology is relatively low. If you follow the babies up from antenatally, the likelihood is that the renal pelvis dilatation will persist, but the likelihood that there will be any surgical intervention isn't really that high. So for mild, there's in this series about 10% likelihood of any surgical intervention. Even if it's between 10 and 15 millimetres, only a quarter of them will have any surgical intervention. So even if the pelvis dilatation persists, often it doesn't lead to any particular treatment unless it's severe. So it's worth following up. If it's getting worse, it's much more significant than if it's simply persisting. When it's moderate hydronephrosis, a couple of comments. Bilateral tends to resolve, even in unilateral. Minority will persist. The bottom 2 points, UTIs, they do occur, but they're no different to the general population. And the likelihood of vesicular-ureteric reflux is really no different to the general population. So I guess what I'm saying there is that just because there's a bit of renal pelvis dilatation, I never recommend MCUs. Yes, it might be reflux, but it's no more likely to be reflux than anybody else. So recommending MCUs in the absence of UTIs, not a particularly useful thing to do. Severe hydronephrosis, on the other hand, well, there's more likely to be some significant abnormality, which is most likely to be pelvic-ureteric junction obstruction. A significant minority will have a higher grade of vesicular-ureteric reflux, and grade 3 probably a little bit more likely to be treated. Even then, likelihood of UTIs generally higher than the population, but not spectacular. PJ obstruction, dilated renal pelvis, plus or minus the calyces, abrupt cut-off just beyond the kidney are the diagnostic features. Again, the important things to mention here are cortical echogenicity and cortical thinning. So images up the top, cortex looks a bit thinned and echogenic, whereas despite the renal pelvis and calyceal dilatation on the images, inferiorly the cortex and the corticomedullary differentiation looks pretty normal. Important to look for the ureters. I know the ureters are hard to see between the kidney and the bladder, but it is important to adjust the settings on the ultrasound, as you can see on your top left there, especially when there's a full bladder, to look for the ureters. We see ureters often. I won't say all the time, I won't even say most of the time, but we see ureters very often. And generally, if they're less than about 3 millimetres, it's just normal. Most of the time, if they're less than about 5 millimetres, it's of no particular significance. If you look for the ureters routinely, you'll see them a lot of the time. Once you get beyond 4 or 5 millimetres, it's certainly worth following up depending on the circumstances, but not necessarily abnormal. Congenital megaureter, I've just mentioned, it's not particularly common, but renal pelvis association in association with ureteric dilatation, with or without reflux, and may or may not be obstructed. Posterior urethral valves, generally these days diagnosed antenatally. Bilateral usually, unless there's been some decompression in utero, in which case they might have seen perinephric urinoma, or alternatively urine ascites. Ultrasound findings, well, mostly we'll see thickened bladder, despite the bladder being collapsed there. You can still be confident that it's thickened. The ureters will be dilated and usually tortuous. Important things about the assessment of posterior urethral valves is the kidneys. And so where the obstruction is severe and persistent, there's usually some long-term kidney damage, usually not as severe as this, but just to emphasise the importance of some comment about renal echogenicity and corticomedullary differentiation. Here, obviously, not much corticomedullary differentiation, increased echogenicity, and the cortical cysts are all a bad sign when it comes to obstructive uropathy from valves. Okay, so I think I've alluded to transient pelvis dilatation, and so recommendations is that most renal pelvis dilatation will resolve itself spontaneously. If on follow-up the dilatation is progressive, it's a little bit more likely that you'll have a definable pathological cause, and that mild to moderate isolated pelvic calyceal dilatation is a poor predictor of vesicular-ureteric reflux and urinary tract infection. Okay. Summary conclusions, much the same as the last talk, that these days our difficulty in imaging is that we're increasingly used for triage and to rule out or find conditions that aren't there. We have this difficulty of the wording of our reports increasingly influencing subsequent decisions, such as finding a little bit of mild renal pelvis dilatation and recommending a MCU, and that the range of our findings varies from completely diagnostic, such as the pyloric stenosis, through to fairly non-specific, such as the bowel wall dilatation. Thanks for your attention.